Up next, Douglas Sipes and Dr. Stephen Farmer, Assistant Professor of Medicine at Northwestern University School of Medicine in Chicago, discuss medical malpractice reform and quality improvement. What can work?
Welcome, Steve.
Thank you so much for having me.
Healthcare issues today are obviously paramount, and indeed, many would say we have a healthcare crisis. We discuss issues about quality, and a very important aspect to this is tort reform. Are we paying enough attention to tort reform? And if not, what should we do about it?
In 2010, the Affordable Care Act was passed after a very long and contentious discussion. As part of that discussion, tort reform was certainly a major piece of the reform effort that was pushed by some members of Congress. It didn't ultimately make it into the final bill, and some people feel that that's a missed opportunity to improve the system, to make it more efficient and for cost savings. The reality, though, is that in terms of direct costs, the estimated cost of the medical malpractice system in the United States is between $10 billion a year and $35 billion a year, depending on whether or not you rely on estimates based on premiums or whether you go by the estimate from the Congressional Budget Office. Whichever of those two you take, the direct costs of medical malpractice, the medical malpractice system, are only between 0.4 and 1.5% of national healthcare expenditures. So even with a dramatic reduction in medical malpractice costs in terms of direct costs, the likelihood of substantially changing medical spending is relatively low.
So it really is a two-edged sword, isn't it? One is the dollars. The second is quality. As an example, we all are aware that many physicians practice legal medicine, ordering the skull x-rays in a 3-year-old who bumped his head, and so on. Will attention to these issues affect quality as well as cost?
I think that's an important point. There's the direct costs of the malpractice system, and then there's the more hidden, more difficult to estimate indirect costs commonly attributed to defensive medicine. If you ask physicians whether or not they practice defensive medicine, almost every person that you ask will recount cases where they certainly have ordered tests that they otherwise didn't feel were absolutely necessary in a particular case. And in Dr. Michelle Mello's estimate of healthcare expenditures, she estimated that while the direct costs were $10 billion to the U.S. healthcare system, a further $45 billion were attributable to defensive medicine practices. So the question is, does defensive medicine actually improve quality, and does medical malpractice deter negligence? I'm not sure that it effectively does that for a variety of reasons, not least that the majority of adverse events never go to court and face any kind of malpractice claim. Secondly, because our ability to identify adverse events even is very limited. So using administrative claims data, the rate of identification of adverse events is much lower than if you go through and do manual chart reviews, which is much more time intensive, even in states which have registries. So I don't think that patients, if the regulators and hospitals are unable to identify adverse events, patients are similarly unable to do that, and many adverse events don't ever get addressed.
Some systems have advocated openness, so physicians are protected and encouraged to admit errors. Has that had a beneficial impact?
The traditional tort reforms, which are attempts to modify the legal system to decrease the rate of claims and decrease the cost of the malpractice system, have largely been directed to reducing the likelihood that patients can make claims and reducing the amount of claims that are made. Those have largely not produced savings benefits that were expected, and because very few patients actually file a lawsuit once they've been injured by medical negligence, it hasn't addressed successfully safety issues. I think that more recently there's been a push towards alternative ways of addressing medical malpractice or adverse medical events. One of the biggest prototypes of that is University of Michigan, in which they have championed the early disclosure and compensation model where the hospital proactively investigates adverse events, thoroughly investigates the cause and whether or not there was actual medical negligence involved, and makes an early offer and has greater transparency for the patients that were injured.
And does that work?
The jury's still out on that one. We don't have rigorous long-term evaluation of these types of programs. There has been money allocated to assessing these programs, but I think that the greater transparency and the effort to shift the blame from individual physicians to looking at the system and how the system can be improved would be a much more effective way of addressing errors.
So is this issue really being blown out of proportion? How many adverse events actually result in a lawsuit? You suggested earlier that it was not that common. And then of those that have a lawsuit, how many actually get to court where you read about these tens of millions of dollars of a jury judgment?
You know, the evidence here is that even in an intermediate risk specialty, the likelihood of facing a claim by the time you're at the end of your career is very high. The fact is that most people's experience with the malpractice system for much of their career is filtered through the media. And the stories that end up in the newspaper with the big headlines are the spectacular cases with large payouts. The reality is, based on the Harvard malpractice study and also more recent estimates of claims made, that only a tiny proportion of adverse events that are due to negligence ever make it to court. The estimate from Studdart's group is that it's approximately 3%. So it's very rare for adverse events ever to go to court. And when they do go to court, the likelihood that the plaintiff will succeed in suing a physician is actually no slam dunk, even when there's definite error involved. So I do think that the belief that everybody is facing an incredible malpractice burden is largely overstated. And I think that people don't have a really good sense of what their true risk is.
The final two sentences predict the future.
I predict that there's not going to be any watershed change across the country in the near future, and there's going to be a more emphasis on these efforts to address medical errors outside the judicial system.
Excellent. Thank you very much.
Thank you.